Osteoarthritis. A joint is situated where two bones meet. Joints allow movement and flexibility of various parts of the body. The movement of the bones is caused by the muscles which pull on the tendons, which are attached in turn to the bone. Cartilage covers the ends of bone, and there's a small amount of thick fluid between the ends of the joint called synovial fluid. And this lubricates the joint and allows frictionless motion between the two ends of cartilage. Injury to the cartilage surfaces that line our joints can occur with jarring injuries or any injury that compromises the stability of a joint. This cartilage is known as articular cartilage, and it's very unique tissue. Again, if you've ever looked at the end of a chicken drumstick, you'll recognize this sort of tissue. It's very smooth, but it also does provide some shock absorption. Chondral injuries do not repair as normal cartilage because of the poor blood supply and the complex four-layered architecture of cartilage tissue. Healing tissue tends to be more fibrocartilaginous scar tissue, and it certainly can do a good enough job in the short term to guard the underlying bone and minimize pain. The main signs of cartilage injury include swelling, pain, and sometimes mechanical clicking or locking if there's a loose body inside the joint. The cartilage does not have nerve endings, and therefore we believe that most of the pain related to cartilage injuries is actually caused by irritation and bruising of the underlying bone. And it's because this underlying bone is no longer protected by the overlying cartilage. We see signs of cartilage loss on x-rays when there's narrowing of the joint space between bones, or when we look directly at MRI, we can see the actual thinning of cartilage qualitatively, as well as any underlying bone bruising. Microscopic fragments of cartilage can stimulate the immune system and result in an excessive production of joint fluid from the inner lining of the joint. This results in recurrent swelling as a common symptom of cartilage injury. So a joint that continues to swell and be painful shouldn't just be ignored. Now, using the knee as an example, you can see here the progression from cartilage injury. Once this injury occurs, a chemical and inflammatory signal can then continue that leads to gradual further degradation of the remaining cartilage. And this is by both enzymes that eat up the cartilage and excessive mechanical forces. Now, bone spurs then form around the joint and spread out the surface area for loading of the joint, and then this is officially osteoarthritis. So osteoarthritis is a big problem in our country. Over 2 million Australians have osteoarthritis, and the estimated costs in direct medical bills, early retirement, loss of productivity is over $5.5 billion a year. It's both a degenerative and inflammatory disorder, and it's really critical that patients learn how to live with it and manage it well. And this is because patients with OA can suffer a downward spiral in health outcomes outside the pain itself. We commonly see that pain from OA can lead to inactivity and then poor dietary habits, and that can lead to weight gain, high insulin levels, exacerbated inflammation, poor sleep, poor mood, and worsened pain, and so the cycle goes on. And if this goes on for long enough, the inactivity and the metabolic deterioration can lead to complications affecting the function of virtually every organ in the body. And this is via high glucose and high insulin levels and their effect on the small and large blood vessels of the body, as well as promoting inflammation and plaque formation in those vessels. The principles of osteoarthritis management are well outlined in the Osteoarthritis of the Knee Clinical Care Standard, contributed to by a number of experts in the field, including myself. It's based on the most evidence-based, highest yield non-operative treatments being used first, with other treatments being considered less essential. Essential treatments include weight optimization through diet, strengthening exercise and activity modification to find the right amount of joint loading tolerated. Every patient should be assessed for their specific biomechanical factors, which should also be optimized as much as possible. And we also know that topical gels can create significant benefit for pain, particularly knee osteoarthritis. Medications including paracetamol and non-steroidal anti-inflammatories should be used judiciously and for the shortest possible period. Optional treatments that are not costly but also not strongly supported by evidence include nutraceuticals like glucosamine and chondroitin sulfate, physical agents like acupuncture, massage, and TENS machines. Now these can be trialled without significant risks, but they haven't got a high profile of evidence. Finally, at the top of the cake are adjunctive treatments like corticosteroid injections, platelet-rich plasma, high hyaluronic acid, or pentosan injections, and these can be considered only once the essential treatments for osteoarthritis have been trialled. The reason is that these tools should really be reserved for patients who have optimized all other aspects of their care, because the effect size of these is on average much lower compared with exercise and diet. Surgery, including joint replacement or in some joints a fusion, is a treatment of last resort. But each tool that we have here is used in the context of each individual's specific osteoarthritis features. I hope you found this video useful. I create these educational videos to help empower patients by allowing them to understand their problem, treatment options, and the expected recovery. Please remember, this lecture is for educational purposes only, does not constitute the giving of medical advice, and no patient-doctor relationship is formed.